don't think I've ever needed the services of this gadget that's right in front of my lips, but still, I'm pretty much audible to all nook and corners, even without the services of this. But even then, good evening, ladies and gentlemen. The reason why I did not expose all the topics to even all the participants is because I wanted the excitement and the drama and the suspense to remain, because I was actually not sure about the number of heads we would have in the audience chairs. And look at this, I was right. Yeah? Right, so I'll begin with whatever little audience we have with a question to the audience, right? So it was one fine drizzling evening in one household where the wife and the husband were sipping the evening coffee and were watching some TV at the same time. There was a quiz show being telecast at the same time, and a question popped on the screen. Which is the largest bird in the world? The husband said, it's the ostrich. The wife said, it's the pigeon. There was a debate. Who do you think won it?
The pigeon. Wife. The pigeon.
Who won the debate?
The wife.
The wife. Any other suggestions? No other suggestions. So it's a unanimous verdict that the wife won the debate. And from amongst the respondents, do you think the wife won the debate because the husband gave in, or because she was scientifically correct?
She was scientifically correct.
She was scientifically correct. Nice suggestion. Satyajit, what's your opinion?
Scientifically correct. I don't know whether what I am saying is correct or not, but
I think you were going to choose the other option, but there was a glare and a torque of the neck from this side, and
But that's not right. Even before we started the debate, it goes to say that whatever argument...
I'm not saying, we are not being judgmental here. We're just trying to take opinion from the house. We are trying to take Janta Janardhan's opinion. Now, if the participants are Janta Janardhan, I can't help it, because there are audience who are not responding. Right, so let's conclude that the husband gave in. And if the husband would not have given in, the house would have been converted to what we are discussing, a house on fire.
very good input.
The only difference between that debate and the one that's going to follow is that we did not have neutral minds to judge who was right. Today we have 4, one of them is missing at the moment. Let's call them in to occupy their chairs first, starting with Dr. Virendra Agarwal. The ophthalmologist husband, whose ophthalmologist wife is not there in the conference, so he has more liberty to speak whatever he feels like. We do have Dr. Monica Jethani. Please come in. The ophthalmologist wife, whose ophthalmologist husband is there in the venue but not in the hall at the moment, and who runs a reputation that once he starts speaking, everybody keeps mum. And I'm parley to that. I can vouch for that to be the truth. Then we have Dr. J. Aditya Kelkar. I must say that she was the most excited participant in this session. She's really shown her excitement right from the word go. Another ophthalmologist wife, whose ophthalmologist husband is not there in the venue, and he has no chance to be here as well, so she also is at liberty to speak her mind. With your permission, chairs, can we begin?
Yes.
So coming in first would be a couple from West. The Kartavyanishth Kankariyas is how I address them. The husband's addressed as Howdy Verdi. So Vardhaman Kankariya and Shrutika Kankariya would be the opening pair for this session. As he gets ready and plugs in, we only have one podium, but luckily we don't have a session following this. So this would conclude the day. So we can just stretch it, no problem with the changeovers. Vardhaman, can we have your first slide? So the motion for them is, as you would soon see on the screen, the motion for them is a 65 years old gentleman a 65 years old gentleman has a grade 2 cataract, a best corrected visual acuity of 20 by 50, a moderate NPDR, and a macular thickness of 200 microns. Grade 2 cataract, BCVA 2050, moderate NPDR, obviously is a diabetic, and a macular thickness of 200 microns. Your approach to this patient would be, Birdie is going to speak on cataract surgery first, look at the macula, and then plan accordingly. What Shrutika is going to speak later on is something that it obviously would be diagonally opposite to that, but we'll look at that later. Birdie, are you ready?
Yeah, I'm ready. They're just connecting this thing. So first of all, I think before I start, thank you, Dr. Anurag bhai, for setting all our houses on fire with this show. And I think this is a very unique concept. And I think we hope the ball gets rolling soon.
So beware of your spouses that your computer may be hacked. I am thinking the same is going to happen to Vardi. And he wanted house to be on fire, so he requested Anurag that keep me first.
Maybe this sets the tone that they are not
Right.
allowing the wife to go first. It's always ladies first. And
No,
there he
no.
is barging in.
That's not true.
No, no,
That's
no,
not true.
no.
If moderate is there,
The
they-
second person gets a better chance to.
That's not going to be the trend.
So, see, moderators are already biased.
No, we are
Before
panelists.
the debate has started.
We are panelists, we can panel you.
It's a jury.
No.
A participant
No.
has just contempted the jury.
Yeah. We can penalize you.
The participant is getting cold feet, I think.
That participant needs to be off his blazer when he comes to the podium.
Yeah.
One more husband is required as jury.
No, he is coming.
This lady's husband is on the way
Huh.
and he's actually
Two.
running amok.
Yeah.
But it's his own instruction course that he's going to leave and come.
No, he got instruction from her. That's why he's not here.
All right.
Vardhaman, are you ready?
Yes.
Your
thank
3
you.
minutes start now.
Thank you so much. So, yes, again, thank you so much, Dr. Anurag bhai. And of course, I love my wife. This is how we are. Okay. But on the same days, there are situations where we don't agree. And that's when this is what we see. So the case which was given to me is 65-year-old gentleman presented with BCVA of 2050, has a grade 2 cataract with a moderate NPDR and a mild diabetic macular edema with 200 micron thickness. And I'm going to speak to you about why I would actually choose to do a cataract procedure and then possibly evaluate the retina progressively and then only think about giving an anti-VEGF or a Ozurdex implant. Actually, further relevant evaluation for this patient showed that he had a very good glycemic control of HbA1c of 6.1. He had history of angioplasty, which was done just 6 months ago, and potential acuity meter, which is a decently good macular function test, gave a potential vision of 20/20. And 200 micron is a very mild diabetic macular edema. So why would I choose to do only a cataract procedure? What exactly I would choose? I would definitely choose a microincisional phacoemulsification with a hydrophobic implant with a perioperative good glycemic control and perioperative topical NSAIDs for this patient. And I would like to carefully postoperatively observe for macular status with a macular OCT and then only decide if anti-VEGF or Ozurdex implants will be needed. During cataract surgery, it's very important that actually all your maneuvers have to be kept to the minimal. It should be a microincisional phacoemulsification, no iris touch because you don't want the ocular ocular barrier to get basically get compromised. Use only direct chop technique so that your energy level is also kept to the minimum and you actually release less amount of prostaglandins. There have been studies which have shown that with diabetic macular edema, if you actually perform a good uncomplicated cataract surgery utilizing phaco, it may not lead to progression of mild diabetic macular edema, especially if the diabetes is under control and is seen to be excellent, which was the situation in this case. And why I will not give a simultaneous anti-VEGF injection in this specific case, because of course we are dealing with only 200 microns of macular thickness. Our usual macular thickness goes to about 160, 150 microns, so it is very mild edema. And the PAM, which is the potential acuity meter, is 20/20. That does demonstrate that the majority of the visual compromise has been because of the cataract, not because of the macular edema. And I definitely feel that the anti-VEGF at this stage may not be needed, and if it can be required, it can be given in the second sitting by doing a serial macular scan, because studies have also shown that if you give a simultaneous sitting of anti-VEGF with cataract versus sequential, the outcomes, final outcomes in diabetic macular edema doesn't change at all. And it also avoids extra intervention in diabetics, which can increase the chance of infection. And of course, there can be a chance that I would prefer a Ozurdex versus the anti-VEGF in the future, especially this patient had undergone angioplasty just 6 months back, so which is a relative contraindication for anti-VEGF injections. Thank you.
Thank you, Vardhaman. Shrutika, it's up to you now. So the point that he's essentially trying to make is you're trying to bring in a cannon to kill an ant. If you are flattening the macula first and then proceeding for cataract surgery, the patients come to you with visual issues. He doesn't know what's wrong with his lens or with his macula. You must give him his vision back. A grade 2 cataract itself can produce a visual acuity of 20/50. So just clear his vision first, look at the macula, and then proceed. You're running away? I was actually going to send it to the Limca Book of Records because this was going to be the first timer. Okay, the laser torch. So it's the same motion for Shrutika as well. The same gentleman, 20/50 vision, grade 2 cataract, moderate NPDR with a macular thickness of 200 microns. She says that she'll put in an anti-VEGF first, flatten the macula, ensure that it's healthy, then would think about cataract surgery. In fact, take up the patient for cataract surgery. So she wants to play a little more conservative on that front. However, the expenses on the pocket of the patient would be a little more taxing. But she is going to defend it.
Does anybody have an adapter for the MacBook Air?
Of course.
Yeah, thanks.
But where's my bag? Oh.
Sorry.
You are the bikes. You are the roads. So the protection it offers is not much, but still it will do for the time being. So we just have to ensure that the households do not have baseball bats, but the brooms it can take.
So sorry for the delay.
Shrutika, just remember that Vardhaman helped you fix your issue. Yeah. Just
I'll consider that. Sure.
your 3 minutes start now.
All right. So you all are aware of the case, but we just reiterate. So it's a 64-year-old gentleman who has grade 2 cataract. Best corrected visual acuity is 25, and he has signs of moderate NPDR and macular edema, which is 200 microns. So I want to say, of course, we should go for anti-VEGF injection first, and then cataract surgery. And that's not just what I say, but it's an order, because diabetic macular edema should be a priority. We all are aware of the fact that diabetic retinopathy is known to progress after cataract surgery. We all are aware of that. And I don't say this, but the evidences do. There are ample evidences, I won't go into the details, which say that diabetic retinopathy develops rapidly or progresses after cataract surgery. These are all the evidences, the relevant evidences. Not only that, but VEGF levels have shown to increase in post-cataract surgery. There was a study, a very conspicuous study, which measured the cytokine levels in aqueous chamber 18 hours after the cataract surgery. And they found that there are certain cytokines which levels were highly increased in the aqueous. Those were interleukin 8, interleukin 6, interferon gamma, TNF alpha. and those which increased to a moderate level included VEGF. So we cannot ignore the fact VEGF levels are known to increase in any patient, not in diabetic retinopathy patient, but in any patient who is undergoing cataract surgery, because it is one of the inflammatory mediator. So how can we ignore this huge fact? And why do you dig your own grave? Isn't it foolish? So what do you think? Where are we going to achieve a better quality of vision? Going for cataract surgery first or anti-VEGF first? So what happens if we go for a cataract surgery first? We won't be dealing the root cause. The patient is still going to be unhappy because the quality of vision is still going to be compromised. Maybe the quantitative vision is not compromised, but I'm sure the patient is going to have low contrast sensitivity, and the visual acuity and the quality is not going to be sharp with the diabetic macular edema setting there. And why wait for it to increase? On the other hand, if we get the main culprit out, which is the diabetic macular edema, and then do a cataract surgery peacefully, we achieve a complete win-win situation, a satisfied and a happy patient, and a relieved surgeon. And while doing this, we need to be aware of facts like the HbA1c levels, if any coexisting nephropathy, duration of diabetes, grade of diabetic retinopathy, any cardiovascular comorbidity, anemia, and the compliance of patient. Who knows if the patient will return back to get the retinopathy treated? So it's better to treat the main culprit and the treatment demanding disease first, because cataract can be handled anytime. I don't think I need to defend more, and the debate is done. Thank you.
So I think Vardhaman was the first speaker, so I give chance to the female panelist
is going
to defend.
So we just have time for rebuttal.
Okay.
So Vardhaman, please. She says that she was defending something, and the only sentence that stood out for me from the whole presentation was "Don't be a fool."
So
Vardhaman,
I
your
think
question.
as you have seen, she has put up so much of data and so many interleukins 6, 9, 10, 11, 12, 15, because when you can't convince somebody, you can confuse people.
Yeah.
So I think that is exactly what she is trying to do.
Your response to that, Shrutika?
Well, facts speak for them. I don't need to confuse people. A person who understands will know the facts and will be aware of the facts.
You don't need to confuse someone who's already confused. Your point to him, rebuttal?
So, the person who wants to get confused will stay in a confused state of mind. Who wants clarity will see things clearly and takes fact as it is without presumptions and assumptions.
You're always this calm in the household?
No, she's not in the household right now. So
That's why she's calm. Right.
Yes.
Quick comments from the panel.
Yeah. No, you start, because the first was Vardhi.
Here again, not husband and wife, but I would like to take the side of science, which errs on Shrutika's favor. You have got to definitely treat the posterior pathology. You cannot directly jump to the cataract surgery. And Dr. Vardhaman, you want to call the patient all the time, repeated scan. Each OCT is going to cost 3,000, 5,000. So you want money out of that, repeated visits.
But I have already saved all the money for his anti-VEGF injections.
No, the anti-VEGFs, you have a huge basket right from the cheaper ones to the expensive ones.
No, Avastins is not available anyway now. So I think all the injections that we have are unfortunately quite costly. And I think in this case, because it was a very, very microscopic diabetic macular edema, and studies have already shown that if you actually have a very good glycemic control, this may not progress.
Yeah, but that is something, a huge thing you're depending on. Patients, once they get cataract surgery, they think that's the end of it. Now they are cured of everything
I
and
think
they may
the
not
point
take care
here
of it.
should be definitely to counsel the patient, because what we have to discuss, this is a very dilemmatic situation. And the patient should be given...
Did anybody else see Shrutika nodding? Or I was the only one?
So she's already agreeing with me. So the counseling is of paramount importance. So you have to talk to the patient that these are the two choices. I feel that maybe doing cataract right now is good enough. We will see you, we will keep you under follow-up. If we feel that, okay, the diabetic macular edema is actually worsening, we have the anti-VEGF, and the studies have already shown that even if we do a sequential anti-VEGF, the results are exactly the same.
Yeah, but calling the
Second
patient
thing is
again and
that
again,
we
do
tell
it in
them
one procedure, that's always easier for the patient as well. And you are treating all premium IOL
it's more
patients,
convenient
so
for the patient. It's more
Yeah, it's more
convenient. But I think
convenient.
when it comes to science, the science will be better than convenience.
Convenience is taken into account here for science.
Thank you. So the first thing is, how many of the people in house will agree that grade 2 cataract need not surgery for cataract?
No, that option was not there.
No, I'm saying. So people say that all will do get 2 cataract surgery. There was a micro edema or no edema. There are different OCT machines. 200 for me on Jai's machine, no financial interest, is not normal macula. For different machines, 200 is a edema. So I will just defend on that side also, because it was only mentioned the normal thickness.
Yes.
Never ever mentioned that it is having a actually edema is there or not there. And mild edema, though the diabetes are well controlled, can be treated by just Nepafenic
NSAIDs and steroids. Yeah.
and NSAIDs. So don't require anti-VEGF all time. And the point from the other side was that if we treat edema first, well, after first surgery he will get vision. If it is not going to improve, he will not believe in anti-VEGF for future also. So be careful. The patient should be convinced by the treatment that he is or she is getting benefit out of the treatment. So it is not always required. That is my point. And patient was done with the microsurgery, and we all have evolved to the level where actually we are not inducing inflammations. So the diabetic retinopathy is not worsening in more than 1% practically. The data may be old when the diabetic patients were actually deteriorating, but in present scenario they are not deteriorating. Though our moderator has given the hint in the beginning itself, the always who will win is known to you. So it is the science that who will win is decided by the science. So she may win, but scientifically, if you talk like ophthalmologist, not as a male female, not as a husband wife, I think cataract surgery need to be done first.
Thank you, sir. Yes, Shrutika is nodding again.
So
I
she
think I
agreed
have-
to me.
Thank you.
Being
Thank you
not
so
a wife,
much.
she agreed to me.
That was an excellent opening section that really sets up the house on fire.
Thank you.
You can go and occupy your seats. Thank you so much. So,
Well attempted by the.
I think we would just rearrange the schedule a little bit because Srinivas is the lone warrior on the Western Front. The other warrior is not there. So to give her a fair chance.
You comes from the south, and when the things go southward, na, is not good.
So
So be careful.
we would call upon the third set of participants, the Kashtjay Kashyaps. And it starts with Dr. Vibhuti. Can I have your first slide, please?
So this is my introduction slide, the first
Okay,
slide.
all right. So the motion for both of them is, listen to it carefully. KP sir, please listen to the motion. Okay. So the motion for the Kashyaps is, a young diabetic having cataract and mild NPDR, young diabetic having cataract and mild NPDR, has come back from his trusted eye care center because they refused presbyopia correcting IOL to him. They refused presbyopia correcting IOL to him. What would your second opinion be? He has come to you for a second opinion. Vibhuti Kashyap is going to say that he is going to second them. You're not seconding them?
I'm second and then going.
You're ridiculing them.
Yeah. No.
He will be
going for the monofocal.
That is what I'm saying.
Yeah.
So you are going to you're going to ridicule them, explain we'll live in the present, and being too futuristic is not our approach.
No. That's her topic.
That's her talk? All right. So you stand on with your debate. Dr. Kashyap, your time starts now.
Thank you. So good evening, everyone. So my topic for today is, will a presbyopia correcting IOL suit a patient with mild NPDR? Is it the right way to go? And I will be going against the motion. According to me, a presbyopia correcting IOL should not be put in a patient with mild NPDR. Now, going against the motion apparently has put my house on fire. Why? Because my wife, just like every other wife, loves rings, be it around her wrist, on her fingers, or inside her patient's eyes. But this choice of rings has apparently woken up the Bane in me. Because just like Bane, as a retina surgeon, I was born in darkness. I was molded by it. I didn't see the light until I was already a surgeon. And by that time, multifocal IOLs were nothing but just superfluous rich patient problems for me. So coming back to the science of it, the first and the obvious thing to look after is contrast. Now, since the amount of photons entering the entering the eye is the same, so every EDOF IOL or multifocal, whatever you talk about, they increase the depth of focus at the cost of certain amount of contrast loss. And when you have a patient with a retinopathy, there always will be certain amount of contrast loss. So the patients will not fare good with it. Of course, there will be an impact on the retinal imaging with the optical coherence tomography with respect to a poorer imaging quality, which is a first and foremost prerequisite to evaluate the macula of a diabetic patient. When we plan to go for a PRP, there will be jumping laser pointers, which will make the retinal laser extremely difficult, especially if I have to go in for a focal laser. ILM peeling in multifocal IOLs is a difficult task because the images of the details of the retinal surface, the fine details of ERM, the ILM, the instrument visibility, they jump across the rings. So for a change, if my wife can stop making it more difficult than it already is, let's extinguish the house on fire, choose an IOL without the rings. Thank you. For this is the longest you have heard me out without interrupting.
Even in public?
In public.
That's interesting. So slides were very good, and as a result of that, you have to keep standing there while your wife speaks. So Dr. Nidhi is going to ridicule them. She is going to say that the first center, because she senses that this patient is likely to go away from me as well and go in for a third opinion if the second opinion does not work. Obviously, this patient is inclined to have a multifocal or a trifocal implant in his or her eye. So she is going to convince us that she was right in ridiculing them and convincing the patient that being too futuristic is not our call. So we'll go ahead and implant a multifocal, right?
Yes.
Can we have your slides? Shoot, Dr. Nidhi.
A very good evening to all of you. Yes, so I will be talking about we live in the present and being too futuristic in our approach doesn't deliver the proper treatment. So, Dr. Bain, as I may say, when you say that you don't like rings, I guess that is only when you have to buy them in jewelry form. Otherwise, you are implanting presbyopia correcting IOLs quite a lot, isn't it? So, do you also counsel all your patients choosing these IOLs about the lifetime risk of developing the following posterior segment pathologies? Have you told them about future risk of developing diabetic retinopathy and so on, what you said? Now, the chances of progression of mild to severe NPDR in 5 years is 5.8% only, and the risk for developing macular edema in mild NPDR is 15.6%. Mild NPDR can be controlled by good glycemic control and regular retinal evaluations. So for my patient, preoperatively, I would like to do a FFA to look for extensive CNP areas, do the OCT and look at the macular thickness, and if all is okay, I think I will go ahead with the IOL, multifocal. Talking about contrast sensitivity, would it not happen in a patient who has a monofocal IOL also? In fact, I feel that a sensitized multifocal IOL patient might just present to us earlier if he develops macular edema. Talking about imaging, I think it's the same study in which you said that the image quality was significantly lower, but you did not elaborate this, that this does not seem to compromise the accuracy of the OCT, which is more important. Coming to the visualization of retina, now the wide field contact lens has made it possible to obtain clearer images of the macular area at multiple focal points in refractive or diffractive multifocal IOLs. These can help in your PRPs and PDTs as well. About your ILM peeling, there was a study in which they showed, I don't think you've read this ever, you can coat the anterior and posterior surface of the IOL with Helon, and using a wide field contact lens and slightly tilting the lens, the visibility will improve. Poor visualization due to rings. Now we have newer EDOF lenses, and here the central area is blended and there is no ring. These kind of IOLs have an extended range of vision from distance to functional near. They have a monofocal-like visual disturbance profile. They utilize all the available light without the energy losses, and the halo profile is also less. So there is no perfect IOL that is equally suitable for all patients, but the right choice in it is an individual, customized approach dealing with patients' expectations. So the lifestyle change should be the patient's choice. I hope this will help. Thank you so much.
Bravo. This was a proper debate. Must congratulate both of you. Rebuttal, Dr. Vibhuti.
I would just say that firstly, the studies that she has quoted, may be influenced with us, the researcher's bias, firstly. And secondly, you cannot depend on, the patient following the doctor guidelines of maintaining a healthy lifestyle. So you cannot depend on a patient's lifestyle, compliance to not create a problem later on with his retina. Yes, mild NPDR can be controlled, but will he follow your restrictions?
Your response, Dr. Nidhi.
Well, I think my presentation is my rebuttal to your question. But you do not know what kind of demands young patients have for near and good intermediate vision. And I think that is also because you yourself are wearing glasses and have not gone for any kind of removal. But the demand is, they are very demanding. You have to look after that as well.
That was below the belt, Dr. Nidhi.
Glasses are above the nose. Come on.
The hit was below the belt.
It doesn't transmit so far. Your question to him, Dr. Nidhi. बाद में देख लूंगी.
No need to take
Yes?
Yes,
Okay.
I have seen him implant the IOL himself, but here for presentation purposes, he is going to monofocal, but I have seen him counsel. Also,
तो चुप करके ले जाना पड़ेगा.
I hope this patient never goes back to him at any point of time, because then we will remember this debate even after 10-20 years.
You ensure that he is going to remember it. Dr. Monica, quick comments from, I'll have to select only one panelist because we're a little short in time, sir. If, Dr.
I think
Monica.
I agree with Dr. Vibhuti. More than 200%. I think patients having any diabetic problems or any retinal problems, we should not go ahead with doing multifocal IOLs. So thank you.
No matter how flashy you get, truth wins.
Go home with helmet.
Just in case you're confused, she is an anterior segment surgeon. Virendra sir, quick comments from you.
Looking to the present scenario and situations, I
Looking
think
at the budget scenario.
Present scenario, because she is saying that he is also doing the same. I think just for the fight on the debate side, she took the thing where the people should be with her. So because people are going to implant the same lens, so she has already influenced the decision at home before discussing what to speak by him and her. But definitely this is not the only point against doing multifocals in diabetics,
Dr. Kelkar.
I think.
No, I agree with Dr. I would definitely put a multifocal, and she put her points across very well. She rebutted everything.
Yeah.
For every question that he raised, she had an answer, and it was scientific and perfect. So I go with you.
Thank you, ma'am.
So that's why I said, according to the house,
Aren't you amazed with the selection of the panelists by the moderator? One wife supports the husband, other wife supports the wife. This is as neutral as it can
We
get.
are supporting science.
we are
Husband
support.
is, we have tactically kept him away. Thank you so much,
Thank you,
Kashyap.
sir.
Off you go. Be the podium.
Actually, even in Vardhaman's
And
case,
in-
I was with Vardhaman only.
So you should have spoken it.
I
Time.
didn't allow her to. In come the Sethis.
So what is the
I didn't
topic?
say you're going to be the first
Yeah,
speaker.
that's what I'm
Dr.
saying.
Aditya.
Let her be the first.
I did not say that you are going to be the first speaker, Dr. Aditya.
Yeah. No.
Yeah.
See,
I asked you that question. You said
I
I'm
knew.
going to be the first one. I had
No.
my opening
No, no.
slide depends on that.
And so let her be the first.
okay, do you have the motion on screen?
Yeah, it's supposed to be here.
So the motion is for the Sethis. The motion is, I repeat, for the Sethis. A 52 years old lady has grade 2 cataract, measured IOP of 22 on Goldman applanation tonometer, occludable angles on gonioscopy, and normal feeds. The modality of treatment for this particular patient would be, over to you, Dr. Aditya.
Yeah.
That's how he's popularly known as.
No, he just wants to make sure that
These are called
people
winning
never
brownie
forget,
points.
people never forget the warrior he has so bravely defeated this evening.
Absolutely, absolutely. I agree with you. So I'm going to go ahead and do cataract surgery first. And I'll tell you why. Let's save time. I know it's not chivalrous and we are running out of time, as Sir has pointed out, but only appropriate that the husband goes first in this debate for the sake of saving time. Talking about saving time, let's operate the cataract and be done with it. Saves the patient of being hassle of being lasered, increases the visual outcome from your first procedure, and also is good for all, for your health, for his health, for your pocket. Wouldn't you want to meet your soulmate the first go and be done with it and enjoy a happy, clear, nice life? An American Glaucoma Society survey on practice preference revealed that phaco cataract surgery is the preferred initial surgery approach for 44%, plus minus 32%, by the way, of patients with glaucoma with visually significant cataract. So what does the literature say? Agrees with what I just told you. There's an Eagle study to go ahead and talk about this. So the Eagle has landed. So the literature says that if a cataract is present, removal of the crystalline lens and replacement with an implanted IOL has been demonstrated to widen the anterior chamber even better than iridotomy. So the Eagle study, or the effectiveness of early lens extraction with intraocular lens implantation for the treatment of primary angle closure glaucoma study, talks about clear lens extraction being suitable. I'm not even talking about cataractis. I'm talking about clear lens extraction being suitable answer for PAC, PACG. So my motion goes for cataract surgery straight away in cases of NS2 cataract as mentioned. Eagle study did prospective investigation of 155 eyes with primary angle closure and went ahead and had favorable outcomes. So role of lens extraction in current, another article which supports what I'm talking about, one from Japan as well. So this is not just one husband, but global ophthalmologists agreeing with this motion. So morality, yes, we've got that on our side. What about money? You're talking about money, maybe PI, you think you're saving your patient money, but no. You're not saving money, nor are you saving sight. It's just a moral high ground, but not a foresight. Because this little article here talks about the economic evaluation if you just do PI or repeat PI and investigations and go on and on treating glaucoma and not the cataract. And it says the patient ends up paying more. What about quality of life? Are you preventing progress of the disease but addressing it early? Often bilateral, if not at presentation, will become. And you're correcting refractive error. What our previous speaker said, still wearing glasses, you can even address presbyopia. And what about complications of PI? So, in today's world, less is more. And I think with that, over to you, my better half.
Less is more was followed by a FIN.
Fin.
Fin?
Finished.
She's finished.
His banter is finished.
So,
So,
Dr. Aditya has to say that he would be operating on the cataract, he's treating the cataract, and with the treatment of the cataract, the angle gets automatically treated, and he has got enough evidence to prove that as well. Dr. Sahiba, on the other hand, is of the opinion that you do a laser PI, treat the angle first, make it fall back, open the angles, and then maybe do a cataract surgery. She says all that while still serving her role as a Bhamangini of Dr. Aditya. Dr. Aditya, you have the microphone.
Yeah,
with you still?
I have one more say to this. I was tricked into this. My slides have been shown to her, but I haven't seen her slides, so I'm going to stand in
Doesn't
front.
matter. You just sat here and made your slides. Not that I could change anything in my presentation. Anyway, I think all that anybody could get from his slides was how much water that wife has
Both
put on
of-
the husband. He just kept going on, and all I could see was, I heard nothing what you said.
You heard-
I just could see that water being thrown on the husband. Anyway, let's.
And
Anyway.
the house is on fire, and both of them, their outfits are color coded in the color of ghee.
But they don't want to speak.
So we are actually going to witness an inferno, not just a fire.
Okay. So I guess my able partner over here is too much into private practice, and I really want to ask him, when was the last time you did gonioscopy? Probably when you were a first year resident, when we were still learning. I think that was about 10, 12 years back. So frankly, for all practical purposes, whatever patient that he can diagnose with his limited amount of knowledge of gonioscopy is, he refers to me and I decide. So everything that you heard over here was all scientific data. Is one of those delegates who comes and speaks what is scientifically correct, goes back and does what I'm going to show you. So this is the scenario we're all aware of. And my thoughts are, first, cure the problem, not just treat the problem. So do a laser PI first if you see a case with occludable angles, and then go ahead with cataract surgery later on. So the case in question over here is a PAC, not a PACS or a PACG. So that itself negates all the studies that he's quoted without any basic understanding of what he was searching for. And then again, even if the IOP was just 22, it probably could be higher at other points in time, which we haven't established. And whether the cataract was visually significant or not is not known again. And like I said, gonioscopy could be worse than just occludable angles. The patient could have PAS, etc. Now, first things first, would he have dilated such a patient? He always sends those patients to me for approval, and I say no. So the risk of dilating a patient with shallow angle is also there, although it's very minimal, but it is there. If you want to take a signed consent from the patient, please go ahead and do it. Now, occludable angles are patients who can have eyes with short axial length, which itself becomes a high-risk case for surgery, and the patient could be non-ophthalmic. Also, lens instability is known to cause shallow angles in many patients, which itself can fall into problems with cataract surgery. And the chance of PACS developing into PACG is also close to 30%, so you need to address this problem. Any which way, if we still decide to go ahead with cataract surgery in these patients, this is what your post-op will look like. And so there can be many problems. I'm going to run through all of this and show you one of his videos. This is a surgery performed by Dr. Aditya Sethi. Probably did not come through because he didn't recognize that there was a shallow anterior chamber. He thought he was better than that. So now this surgery is going to go on and on and on because this is how it went. So this was a patient with an extremely shallow anterior chamber. My brave friend kept going on and on. It's very long. Believe me, it's very long. Yeah. So anyway, 2 minutes have passed of the forwarded video. The case has still not started. The first pinch in the rexus itself has still not come. He's trying, he's still trying. I think my time will go up. My time will be up. My time is up. Oh my God. See, that's how long this surgery went on. Any which way. So he's still trying, by the way. And this is a fast-forwarded video. It's not even funny. And then this is. I'm sorry, this is what the post-op result was. Although the surgery, he's a very good, so he's a very good cataract surgeon, but then this is how cosmetically the patient looked like. So these are all of his cases. So this is again a shallow anterior chamber wherein the iris had multiple sutures. These are the problems you can have. You can have decimate membrane detachment because of crowding of the anterior chamber. You can have corneal wounds because of that. One very potential complication which he could be unaware of because of his lack of knowledge of glaucoma is malignant glaucoma. And this is a serious complication wherein the patient has to go in for vitrectomy, etc. But anyway, I'm a boy. How can I go wrong? How can it be my fault? So he's always blaming it either on the, the assistant was not attentive, or the AC was not working, or things like these go wrong in his OT more often than he does. So now my question over here is that is the risk of doing PI high? No. But is the risk of doing a cataract surgery high? Is the risk of not doing cataract surgery high? No. I don't know if the patient even asked for a cataract surgery. Probably he's the one who advised for the surgery in the first place. And also advising surgery doesn't really ensure that the patient is going to go through with the surgery. So if they don't, then there's a very high chance of a PAC patient turning into a PACG in due course of time. And what is the risk of doing cataract surgery high in this patient? Yes. And so is the risk of not doing a PI in this patient. So the literature that he quoted really doesn't apply to our study, and everything that he or I know a little about glaucoma and cataract has been by our mentor, Dr. Ronnie George, and he also himself feels that the PI should be done before the cataract surgery. But anyway, this is who your doctor is. Look at me, I'm still cool, no matter what I do. And any which way, I have a lovely family, and thank you to them for all the support and the love. I still love you.
Anybody has Johnny Depp's lawyer's number?
तेरे को स्माइल चाहिए?
Multiple times through Dr. Saiba's presentation, I looked up the sky and says, "Hey Khuda, bas kar."
You weren't alone. And I was talking to Khuda here.
Dr. Saiba, humor me. In the initial part of your presentation, didn't you say that whenever he finds a shallow anterior chamber, he does send the patients to me for approval?
Yeah.
So if he took those patients up for surgery and then struggled,
Probably
it was with your approval?
No, those were the patients that he didn't even realize had shallow angles. He just saw the cataract. That's why I said doctors who are too much into private practice, they only see cataract and blinking money.
He just see the center of the cornea.
I think
just to the center.
Looking at Dr. Aditya.
Why even look at the patient? Huh? This goes straight to the OT. No, in my defense, rebuttal. I've never seen these guys before. I don't know who they are. I don't know who that surgeon was. I don't know what was shaking.
So you should do gonioscopy to her.
Yeah, definitely.
Just to find out.
The reason why I've not seen those eyes before is because we've not searched properly on YouTube.
So because anything that goes wrong is not his responsibility. It's probably somebody else's case altogether. That's what his answer is.
That's why we have friends and lawyers.
Your rebuttal.
To what? I'm sorry. What was the question?
To whatever you wish. Dolphins swimming in the sea.
Okay. I think when you have specialists in the house, leave it on to them. That's the better way of treating the patient in the fair interest of the patient. And also, there are no shortcuts in life, my friend.
That's why the good cataract surgeries that I've done. Straight specialist, nice.
Panelists,
Thank you.
quick comments. Stay back, both of you.
I think this time I'll go with the lady.
Thank you.
I think Adit is very lucky to have a female wife who is doing work of counseling. Female wife.
I was lucky at female.
Female wife who She is ophthalmologist
You're
and
very lucky.
lucky to have
Anybody else
a
in
wife.
the house
She
who's
knows
as unlucky as
gonioscopy. He is lucky to have a wife. She knows gonioscopy and a point to convince that this cataract need to be treated and better to get surgery done rather than doing PI. That is the important point. She agrees to it that the PI is not required if you do cataract surgery. So whenever patient is not ready for cataract surgery, he refers the go to glaucoma specialist. So either she will do PI and then say after 2 months we will do cataract surgery. So the patient understands that get a cataract surgery done.
Dr. Kelka.
That is the reason you are referring her, na?
But
Agree.
you're being very sweet to go with the minority. Thank you for supporting my husband.
Yeah, again a mesmerizing performance by the wife, just like always. I'm sure at home also. And yes, she put 2 points across that if it's a occludable angle, YAC PI makes your life easier. And yes, was the cataract operable? Did the patient need a surgery in the first place? Also is an important point.
So cataract was NS2, so it is affecting vision. There was no question. The pressure was 22. Just by medicines it can be controlled. And we are not thinking that not doing cataract surgery in time will definitely cause glaucoma loss. So I think scientifically he is correct. But definitely she has given more humor. So we should be with her for humor part.
Yeah, it was. Yeah, we got your point. It was a mesmerizing performance by the wife, is what you say. What I say, it was actually a pasteurizing performance by the wife. She virtually pasteurized her husband, boiled and then cooled.
Now you know I didn't see this. I was not allowed to see the slides.
Because it ended with
Because of ghee.
It ended with I still love you. There was a still.
Still. Or S was heard by you.
Thank you so much, the Setis.
Thank you.
As we move on and call the Joshis onto the podium, Dr. Srinivas and Dr. Deepthi Joshi.
So Srinivas was happy that I am alone, I will not get a chance and fire. Hai na? So now be careful.
I remember 2 lines, and probably it's applicable to this, is just to regard all of us who've been married and who've been married not with our parents' choice. तो 2 लाइनें याद आ रही हैं कि भाई कौन जाएगा आपने से पहले? Okay, fine. Very authoritative में.
नहीं.
ये 2 लाइनें भी actually उसी के संदर्भ.
पीछे हो गए.
वो आपके पास
डर के भाग गए.
भेज रहे हैं.
No, retina is behind. Retina is always behind. हाँ.
बिल्कुल होता है. तो the लाइनें जो मुझे याद आ रही थी इसी के संदर्भ में थी कि भाई अपने खुशी से जो बंदी बने, क्या उन पे आप रहम करो. वाक वितंडा में अगर सर फटे तो बस उनका मरहम करो. So the motion for the Joshis is a 12-year-old child. A 12-year-old child is having Well-Martinsani syndrome and a microspherophakia. The lens of this child needs to be removed because she is showing evidence of secondary glaucoma due to secondary pupillary block. What should be the preferred approach? Dr. Deepthi Joshi is saying that she would do a lens extraction, fixing the bag with rings, and IOL placement in the bag or in the sulcus as the case may be. Dr. Deepthi Joshi, your time to put up your points starts now.
Hello everyone. So debating with Srinivas is not new to me, but then debating on stage in AIOS, I think this is the first time we are doing, and the fire is very hot and still burning between us. Thank you Anurag sir for this fire, and house is on fire. So the question, Anurag sir has already told, 12-year-old child, Weil-Marchesani syndrome, microspherophakia with the signs of secondary glaucoma. And this is my stand. So look at his face. So it is cataract extraction with CTR capsular hooks or IOL placement. So why is this even question asked? Look at the question. 12-year-old child. First of all, a 12-year-old child wouldn't go to him at first point in our OPD. It will come to me only. I am a pediatric ophthalmologist, तो बच्चा सबसे पहले मेरा आता, मेरे ही हाथ ऊपर होता. So that is one. But then whenever we talk about a 12-year-old child, the first thing we consider is the position. The most physiological position of the IOL is either in the bag IOL, which I will always, in whatever be the situation, I try to achieve, because it is more closer to the focal point, the vision remains to be high, and the vision in fact becomes better. So when we are talking about the vision in children is not just visual acuity. There are so many other factors. I was expecting Jitendra Jaitani sir to be here, that he would tell yes, but then I think ma'am alone is here now. So that is not the, so there are so many other factors. He will perform the surgery and go away, and the child comes to me for the amblyopia management. A 5-degree tilt of IOL after SF-IOL, astigmatism ho jayega. If there is a 15-degree tilt, higher order aberrations ho jayega. So that bacha will never have a good vision later, whatever he may aim for. The myopic shift, he is talking behind, forget him. So the myopic shift is high with that of the SF-IOL. I have given references to all of these things. And now come to the second point which Anurag Mishra sir sent me, secondary glaucoma. Oh, I am the only one who does glaucoma surgery in the middle of us both. He doesn't do glaucoma surgery. So if the child, plus or minus trabeculectomy, whatever may be the choice, in this case, I can and I will. He would have had to take my help if really a trap would have been needed. I am really sorry to say that he doesn't do trap. He's a perfect retina surgeon. This I agree, but not this part of it. So, second, अगर सेकेंडरी ग्लॉकोमा में ट्रैप की ज़रूरत नहीं पड़े, forget it, that even if it was not necessary, but with SF-IOL the amount of inflammation, it would become a tertiary glaucoma later. So later my necessary will always be there. Rather send the child first only to me, I would do a better job. So that would be a more better option. So long term, coming to this point, well, he will now tell in his study that sutureless, tuck, fibrin, glue, all these things I do. I don't go ahead with the post era SF-IOL, but then believe me, this is a 12-year-old child. It still has to live this, he still has to live for the next 80 years or so. What is the longevity of such IOLs in case, especially if it is a tuck, if it is a fibrin glue? I went through the literature, even for with respect to Gore-Tex, the longevity is still a question mark if it is about 70 to 80 years of what I am expecting. I would still be in a safer hand when I place an in the eye bag IOL. I will still be happy that this child would be doing easier. So with this, I still have my rebuttal. I am not done with it. Opponent जी, आप अपना बोल सकते हैं.
आइए, वो तो बच्चों को बुला रहा है.
So what I understood from your presentation, Dr. Joshi, is he doesn't look at kids, he doesn't do glaucoma surgeries, he doesn't do cataract surgeries, he doesn't counsel, and the photograph you showed in which he was not gowned, he was not scrubbed, he was just with his gloves on, perhaps evacuating a calazion.
Or maybe cleaning instruments.
Is that what Srinivas Joshi is going in all ins up?
You have to go in Nivas also.
Pars, lensectomy, Bamangini ji, you should stand on left hand side.
मैं गीता पे हाथ रख के बोलता हूँ.
गीता कहाँ है? गीता कहाँ है?
जो भी कहूँगा सच के सिवा कुछ नहीं कहूँगा. Please bring a Bhagavad Gita in front of her and ask her who taught her first the surgeries. Who taught her the surgeries first? If she says that I haven't learned any surgeries from Srinivas, I will quit from AIOS. I will quit my membership from AIOS.
So you quit.
I'll quit my office bearership from AIOS.
And you will quit house
Mishra
also.
Saab.
Please don't be so radical. आप गीता के जगह पे सविता को छू के भी बोलोगे तो भी नहीं लगेगा. All right, Srinivas, your time starts now.
Okay. So here, 12-year-old child, I think she has already told it 12 times. So I need not tell again and again. Microspiropecia, you see the condition of the lenses here. And still she wants to put those iris hooks, what all hooks she wants to put it, place it in the bag and make it non-mutilating. But she did not think what it falls down. What later on it falls down, who has to pick up? Srinivas Joshi.
तो नीचे बैठे रहो आप.
So what is the classical triad? Lenticular myopia, small spherical crystalline lens, angle closure glaucoma and variant. Now this is Dr. Deepthi, you know what is this? This is the Superman Soldier Serum, right? From Steve Rogers in the Captain America movie, where this poor guy, he wants to join the American military. So the scientists found out that give a serum, SSS serum, so that he became like this and he went into the World War. But my dear Deepthi, this is all film. This is, so what's the inventory you have? You have any inventory for this? The only inventory she has is SSS, that is Srinivas and nothing other than Srinivas.
You have somebody else?
So the clear lens extraction and the intraocular lens implantation in the case of microspirophakia, I think I should say that God bless all these people who have done these studies and all these mutilating surgeries, try to bring it to the center, use rings, hooks, all whatever. They all should be in the drama, circus, not in the real life. Capsular hook assisted implantation of modified capsular tension ring. Please read this. MCTR rotation into the back was fraught with repeated adherence of the advancing end of MCTR into the loose back, causing simultaneous rotation of the bag itself. छोड़ दो यार, lens छोड़ दो, bag ही rotate होता है. And this is again said by none other than our own Dr. Sudarshan Khokar. This is one of the very famous case reports, case series, what he has done. And look at this single eyelet. They said that the authors did not employ two eyelet because they thought the technique was difficult and less repeatable. Look at this, the clinical spectrum surgical outcomes in spirophakia. They also did all the procedure, which unfortunately my wife is still trying to do that. But what is the result? However, the author still favored the anterior chamber IOL. Oh my God. So he was so much away against these hooks, rings and bringing it and try to fear that the lens might fall down. So this was said by Deepthi in the recent March 8th. That is the Women's Day. Gender equality today for a sustainable tomorrow. That's the theme for Women's Day 2022. And she addressed our 300, 400 employees with this great saying. Gender equality. But this doesn't mean that I respect gender. I agree. But that doesn't mean that I cross my boundaries. If a case of this happens like this, I doesn't put a buckle under the lateral rectus and try to restrict that muscle so that it becomes an orthophoric. No, I don't try to do that. I am a vitreoretinal surgeon. I am a happy surgeon. I try to send these cases to Deepthi itself. So one has to know their boundaries, should not cross the boundaries because it is gender equality. So this is phacoemulsification. अरे यहाँ तो बोलने दो भाई, यहाँ तो बोलने दो. Phacoemulsification combined with supracapsular as scleral fixated intraocular lenses. My dear wife said that, okay, he does that, but the capsule can still be preserved. You can always retain the capsule because the SFIOL entry happens through the anterior route. You can always rest the SFIOL on the anterior route. Now, where is the problem of tilt, astigmatism, field, rotation? कहाँ आता है? Capsule पर ही रख सकते हैं ना? तो tilt कहाँ का आता है? These are again, there are various authors can do that. So one thing I finally realized, I want to tell it to my wife, that whenever there are certain things, whenever it comes to our patients, there should not be an ego. Because your ego is not your amigo. Your ego is a constant filter that is distorting your reality and providing you the bad information. It is like wearing a pair of prescription glasses that are unfortunately wrong prescription, my dear. They're wrong prescription.
So you learn the refraction now.
So I cannot use this word. Of course, I don't have the audacity to use that word. But the great saint, everybody follows him. What he says? That the ego must be obliterated. In any such cases where it requires a VR intervention, when she has a husband who is a VR surgeon, where comes the ego to refer those cases?
So you should
Your Honor, I rest the case to the fine sense of your judgment.
Yeah.
Thank you very much.
Yeah, rebuttal.
Sir. Alternative, what she was telling, sutureless, glueless and all less, na? This is nothing.
No less.
This is nothing. Very simple technique. If she wants, she can come. I can teach her. The ego again should not come in between the pediatric surgeon, glaucoma surgeon and the vitreoretinal surgeon. Sir, basically we are all
So
surgeons.
try to be
sir.
friendly at home.
We are all surgeons. See her. She's a good homemaker. She's a good housewife. She's a good daughter. She's a good this thing, that, Balwan, everything. Everything. Everything is there here, sir.
श्रीनिवास किसको देख रहा है?
I'm folding my hands to my wife. She's a good speaker. She's a homemaker. She's intelligent. She's that. She's this, that, this, everything.
So what
But
she's
only
not?
thing I tell her, please don't sacrifice our patients. Please. God bless you, Deepti.
Who else saw Netaji Subhash Chandra Bose and Srinivas this evening? Rebuttal, Dr. Deepti.
So with the rebuttal, he said yes, everything is done. This is. इसको attach कर दीजिएगा तो. No, one slide I have for rebuttal also.
Yeah, he will attach it later. Now you detach.
Project.
Come with you. अच्छा.
Opponent G.
Sir, उन्होंने इतना
श्रीनिवास
respect
जी.
जैसे किया है तो
This
मैंने
good,
भी
good,
respect दे दिया
good,
है.
good,
So-
good.
So now, last one point. He said everything, yes, done. So then, yes, there is sutureless, glueless, all less, this less, that less, but what about the learning curve? This is SFIOL and the VR. So doing our surgeries, everybody in this hall can do my surgery, but very few people
No.
here can go ahead, can go ahead and
No,
do
I agree.
SFIOL surgeries. So with
Everybody in the hall can
Not do
fix
will
a bag
matches,
with multiple rings. And
Sir, yes, I think. So with this, I think the end is very clear. This is me and this is him.
Srinivas, respond.
So you are holding Superman or you are holding Vivekanand?
Lastly, एक point अनुराग भाई. Common sense is something which everyone wants, Anurag bhai. Common sense is something which everyone wants. Few of them have, but Deepti
She is super common.
and one famous author has said, common sense has now become
Very
an
uncommon.
endangered species. And thank you very much.
Srinivas, do you know how to cook?
Yes, sir. When I say yes, sir, it is yes, sir.
Okay.
Yes, sir.
Is he saying the truth?
No, he can cook.
He cooks
No,
to
no.
survive.
He can make Maggie.
No. I can make certain South Indian dishes which I have learned. sir.
Which are not known to you.
All right, Dr. Kelka, out with your comments.
Yeah, excellent debate. And now that you can cook, I think you have a new chef in the house because I give full marks to Dr. Srinivas. Huh? Cook करेंगे, नहीं.
So he had learned in this short time?
Do we have a session after?
No.
नहीं कह रहा इसके बाद ये हॉल को क्लीन करेगा. अभी हाउस ऑन फायर है ना.
All right. Then we need to hurry.
I think
because
I'm
we
with
have-
Dr. Dipti because in pediatric cases we have to put the IUL in back. And I have seen my husband managing so many microspherophakia cases with fixation of the
on
back.
stage, please.
So she says that the males are required to maintain these kind of things. But I feel females are good and master to use hooks, rings and tighten something. But I think doing it through posterior route will make sense. That is my thing. No, the reason is that doing wheel marchesani syndrome cases, the bag itself is almost touching the cornea. The chamber is not there. And you said already secondary glaucoma was already there, means them some other damages were already there. And you said we don't know the longevity of the sutures. In these patients, you will require them. You can't do without that. So that was the truth not given to the audience.
All right,
So
we
I
lost-
think doing it through the posterior route will
Sorry,
make
sir.
sense.
Sorry to interrupt you. On behalf of a house which is already on fire, I request the hall managers to give us 10 more minutes additionally so that we can finish off all the motions. The Sansanike Sinhas up on stage, please. The motion for them, please put up your slides.
सिन्हा तो बार बार बोल रहा है कि वाइफ जीतती है, जीतेगी. ये तो मान के बैठा है, ये बोलेगा भी नहीं शायद. ये पॉलिटिशियंस यहाँ नहीं बोलेगा ये.
So the Sinhas have a center in Patna, and the motion for them is your center has a good optical diameter already. Center has a good optical diameter and a standard spectral domain OCT. You suddenly out of nowhere receive a grant or a fund of 1 crore from some source. Which of the following equipments should come in next? The choices are a ray tracing aberrometer and the best anterior segment OCT vis-a-vis the top of line OCT with OCT angiography. No need to say which Dr. Satyajit Sinha would want in a setup. Satyajit, you're good to go. Your time starts now.
Thank you, Anurag, for that opportunity. In this hall, you must be noticing me going for coffee, going to the bathroom. The tension and the worry was showing. So when I saw that 1 crore, I'm hoping that Anurag will someday arrange to get it sent.
Yeah.
And now I'll be talking about ray trace aberrometer and anterior segment OCT. The day has absolutely gone where you could, 1 minute.
नहीं, 1 नहीं 5 करोड़ आ रहे हैं.
So he also occasionally shows urgency if it's not his wife's call.
I'm sorry about that. Please pardon me. So the days of doing the cataract surgery in which you could just use a monofocal or you could just make the patient slightly myopic and leave them has gone. And slowly, I believe in the next 5 years, the patient will definitely come and tell you that I need a multifocal, I need a EDOF lens, so on and so forth, like those premium lenses. And for these premium lenses, you will need these ray trace aberrometers and anterior segment OCTs. So, and as we all know, we have been studying and growing that cataract surgery is the bread and butter of ophthalmology. Although after I've been seeing Dr. Pooja putting this Avastin injections, I think anti-VEGF injections, I think that has become the bread and butter. But cataract still remains one of the main these things. So I was thinking of what should I actually say that would make sense of why an aberrometer is important. So I actually wanted to add up the incidence of all the anterior segment pathologies like the tear film pathologies, the corneal pathologies, anterior chamber, right up to the lens as is in the anterior segment, as compared to the incidence of all the diabetic retinopathy problems and so on and so forth. So it turns out that the incidence of higher anterior segment pathologies are higher than those of the posterior segment. But in coming times, like we say in 2050, India will be the diabetic capital of the world. At that time, the incidence of posterior pathologies may be higher, but at this point of time, the anterior segment pathologies are higher, because of which we need more anterior segment machines at this point of time. So we have a choice between 2 machines. One is a thing which does auto-refraction, corneal topography, ray trace aberrometer, pupillometer, and keratometry. And this also almost costs as much, is as costly as buying a OCT-A, about which Dr. Pooja will be talking. And we all know that visual acuity is primarily determined by the tear film dynamics, about which so much is being spoken about. So many new machines have come. If you just want to go about buying anterior segment machines just for the tear film, you will have to invest about 1 crore of rupees for corneal aberrations, the pupil size, lenticular aberrations, and the retinal pathology. But you will see that 4 of these pathologies which are there on the top are more than one pathology, which is just the retinal pathology. In routine practice, optometrists used to take care of the low order aberrations, but now that is not acceptable. Your patient will definitely tell you time and again, उनको तो लेंस लगा था, उनको तो बिना चश्मा के दूर और नज़दीक सब बढ़िया दिखता है, हमको तो नज़दीक देखने में दिक्कत हो रहा है. So now more and more you have to deliver to the patient, in which you will have to come to the premium lenses. in which Indian companies are also helping us, and they are coming out with cheaper IOLs which will make multifocal more affordable for the common masses also in coming times. And in fact, now multifocals are out. Now you have to only talk about trifocals and EDOF lenses. These conventional multifocal lenses are totally out because of the glare that they give. And now just to give a small preview of about why we need these ray trace aberrometers is because of these low order aberrations, higher order aberrations. Low order we can take care of, but high order is something we need to speak about. Coma is there, and so many things are there which the aberrometer takes care of. Now, just to understand what is wavefront aberration, if we just presume and look on the slit lamp of the patient and say that the cornea is well good and you have grade 2, grade 3 cataract and you're good to go for cataract surgery, is now not good enough. You have to take care of the cornea in detail, otherwise you will have a complaining patient. Most of us will realize here that the patients that who we were getting surgery के बाद गड़ते रहता है, पानी गिरता रहता है, I think that period is now over. Now we have fewer patients like that, but now patients who are complaining of glare and all are more. So the trace aberrometers gives us so much more information. I'll just move on to the anterior segment OCT and take one more minute. In this picture, you will see that you get so much information about the cornea, about the angles, about the iris, about the lens, which the anterior segment OCT gives you, and it is still costing the same amount of money as the OCT A will cost. They give you high definition images of the cornea. You can make it so close up. You can see acute eye drops. You can see corneal ulcer depths. You can see keratoconus. You can see intracorneal rings. You can see the pterygium when it is excised, the depth. You can see subconjunctival tumors. The tear breakup time study and all is now so much redundant. There's so much more machines have come for dry eye disease management. Anterior segment OCT is also very crucial when you're doing biometry, which needs so much perfection these days. You can see the depth, you can see the angles, you can see the synechias, you can see the conjunctival cyst, iris cyst, so on and so forth. And also in femtosecond cataract surgery, it is so important, the corneal incision integrity, the DM detachment, location of stability, dark demic, so many things the anterior segment OCT helps you with. And in a non-resolving patient complaining of poor vision, you can do the anterior segment OCT and see if the endothelium is detached. And here also you see Descemet's detachment, deep stromal scar, granular dystrophy. You can see the integrity of the main incision in the OCT also. Things like LASIK flap if your patient is complaining. So in routine practice, without doubt, anterior segment OCT and aberrometer is a must buy for today's practice, even before OCT. But I must agree, and I'll have to say that instead of investing into a very costly OCT, and definitely not an OCT A, OCT is very important. You cannot do without making sure that the macula is absolutely fine. But at this point of time, I don't think OCT A is important. Thank you.
And Dr. Pooja gracefully says she agrees. Am I right?
Thank you so much, Dr. Anurag. And I think my rebuttal has been made more simple now, because let me ask the house one simple question. If you have a television, will you invest more technology in saving the picture tube or in polishing the screen? So with this, let me start my debate. I will make it simple through the talk. So this is a first post-op day morning for an anterior segment surgeon, and he has a crying patient over here. He has done a wonderful surgery, but the patient is very unhappy, a diabetic patient. And this was the situation. This was his fundus examination. Right eye, you could see some hard exudates, some hemorrhage, but the media was very unclear. Very poor, simple OCT was there, to document things. And thus, lo and behold, after a beautiful cataract surgery, this is what happens after 15 days. There's gross macular edema and the vision is poor. The patient is very, very unhappy. And now comes to his rescue, the able vitreoretinal consultant and his wife, and she gives an anti-VEGF injection and see how nicely the edema is coming down. But the patient is still unhappy. Now, the situation 2, where you had this dense lens haze, but there was some intelligence in the husband, and a good OCT was done. Edema was documented. anti-VEGF was done, and now you see that even the edema is taken care of. Now you see this picture on the right hand side, a normal looking retina. You place a premium IOL in this patient and you don't do a good OCT, and you see that there is a very fine ERM. Do you think the patient will be very satisfied post surgery? Now I would definitely choose a spectral domain or a swept source OCT in contrast to a time domain. I think everyone agrees spectral domain offers 20,000 to 40,000 scans per second. Increased scan rate and number diminishes the likelihood of motion artifacts, enhances the resolution, and decreases the chance of missing lesions. And swept source technology is even further. Lot of uses of OCT. This is not for debate. I mean, everyone knows so many uses of the OCT. It is also useful in the optic nerve, in the anterior segment. So now the audience can decide whether you want images to be looking like in the top left corner or the bottom right corner. OCTA has a lot of advantages. As my worthy opponent may not know, this is a non-invasive technique for imaging the microvascular of the retina and the choroid, accurately depicts moving artifacts. I would, with my 1 crore, like to choose one of these three, the Zeiss Angioplex, the Topcon, or the Heidelberg. Advantages, everyone knows. Who wants to do an FFA and then face an anaphylactic reaction or with an injectable dye? OCT has so many advantages: diabetic retinopathy, dry, wet, age-related macular degeneration, CSR, you name it, and OCTA has answers to what we didn't know earlier. Glaucoma, it is useful in depicting optic disc perfusion, uveitis. This is a Best disease with CNVM. So elegantly, I could, make out the CNV complex on the OCTA, and the patient was treated accordingly. A post-traumatic CNVM, you see that with anti-VEGFs, the hemorrhage goes down, the edema goes down, the CNV complex resolves. But on OCTA, still the CNV complex was persisting, which called for more anti-VEGF injections. A multifocal CSR, this is to also show that an FFA is also useful in some cases. You see these multifocal leaks. And the OCTA, this is an elderly patient, and I wanted to do an OCTA to rule out a CNV complex. Just the last patient, a diabetic patient, no diabetic retinopathy changes, in for a cataract surgery with a premium IOL. And you see that on OCTA, the foveal avascular plexus is not densely packed. You warn the patient that 6 months or 1 year down the line, you may get some diabetic changes. So, Dr. Satyajit, would you like to be the anterior segment surgeon in the first picture, or would you like to be an anterior segment surgeon who is a happy surgeon with a well-counseled patient? And this is my last slide. Even the Supreme Court has said that wife is always right, and 9 out of 10 husbands agree that their wife is always right. The 10th one mysteriously disappeared and hasn't been heard from since. Thank you so much.
The author of that tabloid was some Dhananjay Mahapatra. He's in Odia. Right. With the permission of the panel, we would just finish off all the presentations first and then take your opinions, because we're running slightly short on time. However, Satyajit, we are not going to be skipping the rebuttal. The Mahir Mehras come on to the podium first, and the Sinhas will just shift a little aside.
I think there is no rebuttal in this case, because this is the decision is out.
I'll agree if your husband agrees.
The verdict is already out.
सत्यजीत अभी बैठ जाओ, टाइम बाकी है. सत्यजीत बैठ जाओ, अभी तुम्हारा टाइम बाकी है, तुम जीतोगे, चिंता मत करो.
OCT एंजियो ऑलरेडी आ गया है क्लिनिक पर, आप छोड़ दो ना, कहाँ आर्ग्यू कर रहे हैं?
उसके
ऑलरेडी कम, वो बाद में बताएंगे वो.
Just wondering if had I given them a choice that you have 1 crore
to buy jewelry
and you don't have to buy any equipment, then what would your choice be?
You will keep it on the fixed deposit. That is a better option.
Dr. Rohan and Dr. Pooja Mehra would be standing against each other, and the motion for them is a 36 years old female. A 36 years old female has high myopia, an anterior chamber depth of 3.2 millimeters, and an endothelial cell count of 1200 cells per millimeter square. She wants total independence from glasses. The modality you would choose would be, Dr. Pooja says that she would do a phakic IOL placement from the most trusted manufacturer. What would Dr. Rohan say is something would come later. Pooja, you ready? Yes. Your time starts now.
Good evening. I'm Dr. Pooja Mehta, and I'm here to burn it all down and take my opponent down. I'm a director of the Vision Eye Center, Mumbai, and a consultant at CKI Institute. So motion that I've got is a 36-year-old female who is a high myopic, has an ACD of 3.2 with an endothelial cell count of 1200, and she wants total independence of glasses. So what does a refractive surgeon do? It's not going next. So definitely I have chosen the modality is placing a phakic IOL placement from the most trusted manufacturer. The reason being, I have chosen phakic IOL from a trusted manufacturer because why would I want the accommodation of a 36-year-old patient going away when you can simply put an AC IOL inside the IOL? Can you place a IOL inside the eye? However, I would not want my opponent to remove her accommodating powers and remove the crystalline lens. It's not changed. Also, the patient has a... Also, the patient has an ACD of 3.2 mm and an endothelial cell count of 1200. I'm confident that I'm a pretty good surgeon and I'll be able to have a good wall size unlike him, which he thinks he won't be able to achieve. Also, the complications and stresses of a high myope cataract surgery comes with, having fluid accumulation under the iris or having a PCR and the stresses that follow post-surgery. I would leave all the stresses, of course, on him if he wants to go ahead with that. Also, it's been 8 years plus that we have many papers that have been published on the implications of posterior chamber phakic IOC intraocular lenses in international journals like Frontiers in Medicine, which have an impact factor of 5.049. And I don't think my opponent has ever published any article in such high impact journals. I'm confident that because of innovations with ICLs which have a central hole, there are lesser chances of any complications that can happen. Also, when we have a high myope, the IOL power calculation is so difficult, and when she wants complete independence of glasses, why not give it with putting an ICL instead of having post-refractive surgery complications? Now I'm 100% sure that he'll be thinking in his head, how did I not see this? Do you have an answer to this?
Of course I do. I believe all men are men of steel, because today what we have seen is the wives have just gone on hitting and hitting and hitting, and all the husbands have done is to smile. Yes. Speaks like a true husband. Aap beeti.
All right.
Yes, Rohan. Good to go?
Good to go, sir.
Off you go.
So, while all of you went out, sipped coffee, and saw our house coming down on fire, I will tell you why I am going to be doing a refractive lens exchange in this patient, and I will be knocking her out. So modality chosen will be a clear lens extraction with a trifocal or an EDOF IOL. You've already, seen the toxicology that she gave you. You all drank it. I chose not to, just by the way. So let's dig deeper. Once we dig deeper, this plot is definitely going to thicken. Endothelial cell count of 1200. She didn't even touch upon it. Now she's 36-year-old. 20 years later, she'll have a cataract. She's done the surgery perfectly fine, everything is okay. At 56, do you expect this endothelial cell down to go to 900 or to 1500? That nucleus is going to keep getting harder. She's 50. She'll have an NS1, NS2. Right now, I can do a clear lens extraction with a CDO of maybe 1/2, whatever, and protect this endothelial right here. Secondly, we are doing 2 surgeries. Once you do an ICL, that time also you're putting in visco or you're doing a hydroimplantation. Who's going to take care of the damage that you're going to cause on that optic nerve? She thinks this is shopping. एक पे एक मिलेगा free, ले लो, पहले एक surgery करो, फिर दूसरी करेंगे. But let me tell you one thing. I am a 2-for-1 pizza house guy. All right. I will do it in one go. ना रहेगा बांस, ना बजेगी बांसुरी. थोड़ा रिसर्च किया मैंने. उसमें क्या मिला कि पेशेंट डिपेंडेंट फैक्टर्स जो थे इसमें इतने सारे थे. एज, जितना ओल्ड होते जाओगे एट द टाइम ऑफ इम्प्लांटेशन, हायर द चांसेस ऑफ कैटरैक्ट. Prevalence of cataract is 4 times higher in patients with high myopia than in normal population. Iridocyclitis होगी, topical steroids भी डालने ही पड़ेंगे थोड़े से ICL डालने के बाद भी, कोई फर्क नहीं पड़ता. Intermediate contact during accommodation. So mechanism of cataract formation, constant trauma, constant between phakic lens and anterior capsule. Center में नहीं हुआ तो periphery में तो पक्का ही होगा. Continuous disruption of blood aqueous barrier caused by friction between iris and phakic lens and ciliary fixation of the phakic lens. Third is metabolic and nutritional disturbance that ICL will obviously cause. अब क्या होगा? She's done it. She's done the surgery. She came back. This patient came back. Now she's telling me, Rohan, cataract कर दो ना. इसका निकाल दो, देखो इसको PSC हो गया है. I didn't listen to you back then. अब देखो मेरे को झेलना पड़ रहा है. She's coming to me. Incidence of cataract, बोलने का ज़रूरत ही नहीं ICL में. कितना, it's so high, and the type also is also mentioned. There have been so many studies to prove this. Incidence of cataract 9.6%, incidence 8%, 3.8 requiring ICL removal and cataract surgery, 8% with mean time of 1 week to 14 months. मतलब 1 week से ही शुरू हो जाता है. अभी रामबाण तो मैंने निकाला ही नहीं है. Next slide is the Ramban, which she has conveniently ignored, and I think all of you also did not notice in the motion.
Except the one who said it.
Yeah, it's not going to the next slide. Yeah.
So there is no Ramban.
Yeah, last slide.
वो उसने रामबाण ने
गलत
सीता के
time
साथ
पे हुआ.
समाधि ले ली.
आ गया.
वो ये रामबाण है.
She is a female. Patient is a female. Who's going to take care of her jig? She's going to come back after the ICL. फिर से आएगी. Who's going to take her jig? She's a female. She's going to say, I don't care. You fix me. Also, yak, 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 yak. Thank you.
I invite the Porwals next, the Paripurn Porwals. Do you have a rebuttal? This is the last motion, ladies and gentlemen, before we conclude. But before we start off and the Porwals get ready with their slides, do you have a rebuttal, Demeraz?
Rohan.
Do you have a rebuttal? Or you think you've fixed
What if you get a post-refractive surprise and the patient is not happy with the vision?
Then you do refractive surgery.
Yeah.
So they both want to serve each other. But I think for this, the take-home message should be that no surgery. Just I want to convey to the house, my opinion, 1200 counts, she should not be offered any surgery, be it a ICL or a cataract surgery. I agree that with increasing age, the cells may go down further, but ideally, nobody should do any in surgery for ICL or lens.
Thank you so much.
The message should be contact lens.
A question for you, audience, or whatever is left of it. Would you all like to see this session happening again in AIOC Kochi?
Yeah.
So if the request from the scientific community...
So if you want it back in the app, give your comments for this session that we want to repeat.
And you accept that you lose. You lose.
So the motion for the Paripurn Podwals is a 58 years old patient with bilateral advanced cataract and a sensory committant exotropia of 35 prism diopters of rather recent onset, bilateral advanced cataract 35 prisms of committant exotropia that has happened recently, the best approach would be Dr. Kavita Podwal, who is going in first, would speak in favor of squint correction along with cataract surgery in the same sitting. Dr. Kavita, are you
Good
to
evening,
go?
everyone. Thanks, AIS, for arranging such a nice session. So I would go for squint correction with cataract surgery.
In the same session?
Yes.
Same session, sir. So sensory strabismus basically is secondary deviation resulting from unilateral visual loss, usually caused by anisometric amblyopia, organic pathologies, optic nerve or retinal anomalies, and corneal opacity and cataract. And it can develop within days to weeks after the onset of acquired visual defect like cataract. Usually, in the first 2 years of life, esotropia is prominent, and by the end of first decade, exotropia in up to 80% of
No,
cases.
patient was 58-year-old.
Francis reported that 36
It was
adult
patient was
patients,
50-year-old,
69%.
So by patient was 55-year-old.
36 adult patients, 69% patient acquired had presented with exotropia, while remaining 31 presented with esotropia. Magram et al. Suggested strabismus in patients over 60 years found sensory deviation in 16% of cases. A pre-existing exophoria or intermittent divergent strabismus may decompensate following development of unilateral cataract. Cases where the angle of deviation is large or strabismus surgery is a cosmetic correction, it is logical to perform both the procedures in a single sitting. Why combined surgery and not a separate surgery? Two goals can be achieved simultaneously. First is correction of strabismus and improvement in vision. Guha et al. Reported that nearly 2/3 of all the eyes had combined strabismus and cataract surgery achieved surgical success after one operation. Two groups were taken. Group 1, those who developed strabismus first and cataract later, and Group 2, those who developed cataract first and strabismus later. Poor strabismus success in Group 1 when the angle of deviation was more than 80 prism diopters, whereas a similar setting in Group 2 the success rate was still 66.7%. The strabismus success appears to be better in Group 2 than compared to Group 1. Sensory strabismus surgery should not be solely regarded as an aesthetic operation, and functional improvements can be obtained it should not be underestimated. Combined cataract surgery with IOL and strabismus surgery can also be considered in those cases that develop decompensated intermittent divergent strabismus due to cataract. The added advantage is less tissue handling in combined surgeries and therefore a better surgical and anatomical outcome. Other combined IOL placement with strabismus surgery. Various studies reports improved visual acuity and postoperative alignment of visual axis with the resolution of symptomatic diplopia. It was first described by Maltzman. Now, in cases with, if you are going to do cataract surgery followed by squint surgery, a patient of unilateral mature cataract will have diplopia following surgery. So, counseling of a patient in two different surgery is difficult. Separate setting for separate surgeries followed by complication due to multiple times tissue handling and the risk and complication of each individual surgeries, multiple visits, cost effectiveness, and cosmetic correction requirement. Combined cataract and strabismus surgeries